Okay, well, thank you everybody for signing in to our topic discussion for this week. We are being led by the talented Dr. Dana Wright, soon to be Dr. Dana
Wafers.
Yeah, so we won't have a Dr. Wright for very much longer. Like I said, we are recording, so keep it clean. And with that, I'll turn it over to Dr. Wright.
All right, thank you, Chris, for the introduction. So today we are going to focus on weight loss medications. Okay, so I'm just going to skip this poll, but it was actually really cool. I was just going to have the participants say what the first thing that comes into mind whenever you hear the word obesity. And you guys can still participate if you'd like. All you have to do is text Dana Wright 288 to 2333 to join, and then just type in a word that comes into mind. So we have diabetes, that comes into mind. Oh, osteoarthritis, hypertension, America. Those are all really good responses. I don't know what MU is. Lazy. Moo. Okay. Anyway, but yes, those are all very popular words that come to mind whenever we think of obesity.
A moo-moo.
Okay, I don't know what that is, but we'll continue. Okay, so since 1980, worldwide obesity has more than doubled. In fact, in 2014, more than 1.9 billion adults aged 18 years and older were overweight. Of these, over 600 million adults were obese. Overall, about 13% of the world's adult population, 11% of men and 15% of women were obese. Not only does obesity affect adults, but an estimated 41 million children under the age of 5 years are overweight or obese. Once considered a high-income country problem, obesity is on the rise in low and middle-income counties, particularly in urban settings. Amplifying the situation is the dramatic expenses. The estimated annual medical cost of obesity in the United States was $147 billion in 2008, and the medical costs for people who are obese were about $1,500 higher than those of normal weight. So I do want to just point out that today, actually, the State of Obesity Better Policies for a Healthier America was released. So I was able to skim through it a little bit, but I wasn't able to really read into it. But I did include a couple figures from this newly released publication. So specifically, this is a map indicating the prevalence of obesity in the United States. I just want to point out that no state had a prevalence of obesity less than 20%. And actually, surprisingly, the lowest rate of obesity was in Colorado at 20.2%. With the recent laws passing on cannabis, it'll be interesting to see the trend of the Colorado obesity rates. But of the 11 states with the highest obesity rates, 9 are in the South, which posted an overall rate of 31%. And then it was followed by the Midwest at 30.7%, the Northeast at 26%, and the West at 25%. According to data spanning between 2013 and 2015, non-Hispanic Blacks had the highest prevalence of self-reported obesity at 38.1%. Trailing them were the Hispanics at 31.9% and the non-Hispanic whites. Actually, 4 states saw obesity rates decline in 2015, and that was Minnesota, Montana, New York, and Ohio. And it was actually the first time any state has weighed less on the scales in the past decade. So nationally, childhood obesity rates have remained stable for the past decade, around 17%. And rates are declining among 2 to 5-year-olds, and it's stable among the 6 to 11-year-olds, and it's increasing among the 12 to 19-year-olds. Obesity rates have become much higher starting in the earlier age. In fact, 8.9% of children aged 2 to 5 are now obese, and 2% are extremely obese. And then I like this graphic too, as it shows the prevalence of obesity among adults aged 20 and over. So the medical rationale for weight loss in obese subjects is that obesity is associated with a significant increase in mortality. In observational cohort studies, overweight and obese adults with type 2 diabetes who intentionally lost 9 to 13 kilos had a 25% decrease in mortality rate with compared to weight-stable controls. Obesity-related conditions include heart disease, stroke, diabetes, hypertension, and in fact, certain types of cancer. And overweight and obese adults at risk for type 2 diabetes average weight losses of 2.5 kilos to 5.5 kilos at 2 years, reduce the risk of developing diabetes by 30 to 60%. Obesity occurs when there is an increased energy storage resulting from an imbalance between energy intake and energy expenditure over time. The specific etiology for this imbalance in the vast majority of individuals is multifactorial, with genetic and environmental factors contributing to various degrees. Observational studies have demonstrated that the strong role of genetics in determining both obesity and distribution of body fat. In fact, the genetic contribution is estimated to be about 80%. A number of single gene mutations producing extreme obesity have been identified, but are pretty rare. The more common allele mutations may only slightly increase the BMI by about 2 kg per meter squared. The total number and identity of contributing genes are still being determined. Due to the advances in technology, lifestyles have become more sedentary. On top of that, there has been a significant increase in the availability and portion size of high-fat foods. The westernized lifestyles are more likely to result in a state of positive energy balance in many individuals. And one thing that I found particularly interesting was that obesity has been reported more frequently among individuals within close social networks, with a person's risk of becoming obese increasing significantly if a friend is obese. So what do you guys think? Which is a common cause of obesity? And if you've already joined the Dana Wright, you don't have to join again. You can just text your response, A, B, C, D, or E. Okay, looks like we got some results here. Let's see what you guys said. So 25% said B and C, and 75% said all of the above. Well, actually, the answer is just B and C. So moving on, I will show you. This is the primary causes of obesity. So it's actually leptin deficiency rather than leptin overproduction. So you also have your genetic causes and your syndromes, such as the Prader-Willi Syndrome. And I want to talk about this a little bit because it's kind of interesting. It's a neurodegenerative disorder that is caused by genetic abnormalities of chromosome 15. The key genetic material usually lacking is in the SNRPN gene, which codes for a small protein thought to be involved in imprinting genes from both parents. So affected infants have poor muscle tone and feed very poorly at birth. But later their appetite becomes ferocious and they become obese, and they often have behavior problems such as irritability, tantrums, and delayed development. And then the Bardet-Biedl syndrome is an autosomal recessive disorder characterized by obesity and other defects such as intellectual disability, renal malformations as well. So then your secondary causes include your neurological, endocrine, and psychological conditions. Interesting, hypothyroidism mostly causes fluid retention, and it's debatable if it really causes obesity or if it just exacerbates the condition. Of course, I want to highlight the drug-induced causes of obesity, which includes the TCAs, contraceptives, antipsychotics, and convulsants, along with the glucocorticoids, sulfonylureas, glidazones, and beta blockers. Although the pharmacological mechanism responsible for weight gain is usually drug-specific, in most cases the precise mechanism is unknown. Obesity occurs through a complex mechanism, but one major factor that affects increasing weight is appetite control. Factors that increase appetite include amines, specifically the serotonin, direct stimulation of 5-HT1A, and also the noradrenergic alpha-2 receptors increases food intake. Many neuropeptides that influence appetite exert their effects within the hypothalamus with signals to the paraventricular nucleus. The key peptide in this area is currently thought to be neuropeptide Y, which is the most potent known stimulator of eating. Orexin also increases food intake within the lateral hypothalamus. Ghrelin is a 28 amino acid peptide produced in the stomach and duodenum, and it's an endogenous ligand for the growth hormone receptor. The peptide has two major effects. It's going to stimulate growth hormone secretion and increase food intake. Serum concentrations actually increase in anticipation of a meal and then is suppressed by food ingestion. And the concentrations increase after diet-induced weight loss. So previously I mentioned that the direct stimulation of 5-HT1A and alpha-2 receptors increases food intake. Well, the opposite occurs with 5-HT2C and then the alpha-1 or beta-2 receptor activation. Your alpha melanocyte stimulating hormone is also in relationship to the hypothalamus and has action at the 3 and 4 receptors and is one of the most crucial inhibitors of eating. Peripheral appetite signals also dramatically affect food intake. Leptin, a hormone that is secreted by adipose or fat cells, acts on the brain to decrease appetite and increase energy expenditure. Of note, recombinant leptin replacement therapy is only efficacious in obese humans who are leptin deficient. In obese humans who are not leptin deficient, leptin therapy has not proven successful because obese humans appear to be leptin resistant. And then your glucagon-related peptide, or GLP-1, and peptide YY are all gut hormones and suppress eating in humans. Now, GLP-1 does have other effects, mostly important as an incretin, which facilitates the release of insulin by your pancreatic beta cells in response to meal-related glucose. So this is just a chart of all of the factors that cause increased eating or decreased eating. And then signals to appetite and controlling centers, like I've talked about, really occur within the central nervous system, in particular the hypothalamus and the brainstem. And those signals come from the gut, adipose tissue, liver, and pancreas. Now, in humans, it's not just these signals, but many other cues such as reward and emotional factors play a huge role in food intake aside from hunger. And another pathway responsible is the reward-associated feeding behavior. These are the definitions. So you have normal weight, which is classified as a BMI between 18.5 and 24.9. Overweight is a BMI between 25 and 29.9. And then you have 3 different classes of obesity, where if your BMI is greater than 40, that is classified as extreme obesity. There are a number of different guidelines out there. The 2013 AHA-ACC 2OS guidelines really cover lifestyle interventions and surgery, but don't talk into detail about pharmacotherapy because there were few drugs available at the time that it was written. So what we're really going to focus on is the 2015 Pharmacological Management of Obesity, published by the Endocrine Society. Now, the Endocrine Society does endorse the 2013 guidelines and states that you also should follow all of their recommendations. So the guidelines outline steps that should be taken when during a patient clinical encounter, with the first step being to weigh the patient wearing light clothing or an examination gown with no shoes, and the weight, height, and BMI should be calculated and documented. Next, the provider should assess the risk of CVD and or presence of obesity-related comorbidities. A waist circumference measurement is recommended for individuals with a BMI between 25 to 34.9 to provide additional information on risk, but it is unnecessary to measure in patients with a greater BMI because it will likely be elevated and will provide no additional risk information. So expert opinion is to use a waist circumference cutoff for 35 inches for women and 40 inches for men as an indicator of increased cardiometabolic risk. Also, make sure to get a thorough history from the patient, as this will help guide therapy. Ask questions such as weight gain and weight loss over time, previous weight loss attempts, dietary habits, physical activity, and family history. And lastly, the clinician and the patient should agree on whether weight loss is appropriate. The clinician, together with the patient, should assess whether the patient is prepared and ready to undertake the measurements needed to succeed at weight loss. A good open-ended question that can provide really good insight is, how prepared are you in making changes to your diet? I almost think of this like the smoking cessation guidelines with the 5 A's and really getting a good history. Because obesity is related with increased mortality and associated with numerous disease states, annual and symptom-based screening for major chronic conditions associated with obesity in all adults with a BMI of 30 or above is highly recommended. This includes screening for diabetes, cardiovascular disease, hypertension, hyperlipidemia, obstructive sleep apnea, non-alcoholic fatty liver disease, osteoarthritis, and major depression. Ensure timely adherence to national cancer screening guidelines with the understanding that individuals who are obese are at an increased risk for many malignancies, such as endometrial cancer and esophageal adenocarcinoma. It is important to stress that setting a realistic and meaningful weight loss goal and communicating this with your patient. I want to point out that one study conducted had patients write down their dream weights, and this was later compared with the actual weight loss. None of those patients had achieved their dream weight, and very few were happy with the weight loss that they did achieve. Thus, the clinician and patient need to come to a mutual understanding of the realities of weight loss. Although a weight loss of 3 to 5% may lead to a decreased cardiovascular risk factors, larger weight losses will produce greater benefit. Therefore, an initial goal should be 5 to 10% of the baseline weight within 6 months. And of course, the overall goal of therapy is to prevent or reverse the complications of obesity and improve quality of life. Now, that being said, all weight loss, or with weight loss, it will require lifestyle interventions. So this is just a brief list of all of the dietary interventions out there, which can kind of be confusing. You have your low carbohydrate diet, you have your lower fat diet, you have your high protein diet. So I want to pose a question out there. Which diet do you recommend for your patient? And again, you can just text to the 2333 number. Okay, so someone said tie. Level 6. That probably would induce a lot of sweating, probably could lose some weight with just that alone. Low carbohydrates, DASH diet. DASH diet is good for hypertension. Okay. So this was actually a trick question because in fact all diets are associated with weight loss if reduction in energy intake is achieved. The only diet that has been shown to have possible more effectiveness is the use of liquid and bar meal replacements. Now, this has been associated with increased weight loss at 6 months in comparison with a balanced diet using only conventional food, but long-term evidence of continued weight loss advantage is lacking, and really the strength of this evidence is low. So ultimately, what it comes down to, the biggest predictor of weight loss is dietary adherence, regardless of the type of diet. Tailoring a diet that reduces energy intake below energy expenditure to individual patient preferences, rather than focusing on the macronutrient composition of the diet, is recommended. The addition of dietary counseling may facilitate weight loss, particularly during the first year, as it can promote that increased adherence. With dietary intervention in overweight and obese adults, average weight loss is maximal at 6 months, with smaller losses maintained for up to 2 years, while treatment and follow-up tapers. Weight loss achieved by dietary techniques aimed at reducing the daily energy intake ranges from 4 to 12 kilograms at 6-month follow-up. Thereafter, slow weight gain is observed with a total weight loss at 1 year of 4 to 10 kilos, and at 2 years, even less, of 3 to 4 kilos. So instead of dietary interventions alone, what we really want to focus on is combined interventions. The most effective behavioral weight loss treatment is going to be an in-person, high-intensity consisting of 14 sessions or more in 6 months, intervention in either group or individual sessions consisting of diet, physical activity, and behavior therapy modules. However, in primary care offices, the electronically delivered interventions using email or phone that uses personalized feedback by a trained interventionist, or your commercial programs that provide counseling can be an alternative mode. And using prepackaged meals is also an option too. But the principal components of an effective high-intensity, on-site, comprehensive lifestyle intervention include 3 basic things. Prescription of a moderately reduced calorie diet, in which individuals are typically prescribed a diet to design to induce an energy deficit of 500 kilocalories per day. This deficit is often sought by prescribing 1,200 to 1,500 calories for women and 1,500 to 1,800 calories for men. Second, a program of increased physical activity, including increased aerobic physical activity, such as brisk walking, for 150 minutes per week. Higher levels of physical activity, approximately 200 to 300 minutes per week, are recommended to maintain the lost weight or minimize weight regain in the long term. And lastly, the use of behavioral strategies to facilitate adherence to diet and activity recommendations. The program should include regular self-monitoring of food intake, physical activity, and weight. These same behaviors are recommended to maintain lost weight, with the addition of frequent monitoring of weight, which is weekly or more often. So when all 3 of these components are included, and should be included for optimal weight loss, it will produce an average weight loss of up to 8 kilograms in 6 months. If permanent weight loss could be achieved exclusively with behavioral reductions in food intake and increases in energy expenditure, medications for obesity would not be needed. Weight loss is difficult for most patients. So the guidelines recommend that diet, exercise, and behavioral modification, of course, be included in all obesity management approaches for a BMI of greater than 25. And then that other tools such as pharmacotherapy for BMI above 27 with a comorbidity such as hypertension, hyperlipidemia, diabetes, or obstructive sleep apnea, or if a patient has a BMI over 30. Medications may amplify adherence to behavior change and may improve physical functioning such that increased physical activity is easier in those who cannot exercise initially. Patients who have a history of being unable to successfully lose and maintain weight and who meet label indications are also candidates for weight loss medication. And then bariatric surgery is recommended in patients with a BMI above 35 with a comorbidity or a BMI above 40 and can be used as an adjunct to behavioral modification. So providers should perform an assessment of efficacy and safety at least monthly for the first 3 months if they are on pharmacotherapy, and then at least every 3 months is warranted in all patients prescribed weight loss medications. The more accountable patients are to weight loss programs, the better outcomes that are expected. The guidelines also give us advice about discontinuation of pharmacotherapy, and this is important. So if a patient's response to a weight loss medication is deemed effective, which effective is defined as a weight loss 5% or greater of body weight at 3 months, then the medication should be continued. If the medication is deemed ineffective, which is a weight loss less than 5% of body weight at 3 months, or if there are any safety or tolerability issues at any time, the medication should be discontinued and alternative medications or referral for alternative treatment should be considered. Again, the trials of weight loss medication that have used a crossover design have demonstrated that the weight loss effects of medications are only sustained as long as they are taken, and these same benefits occur on introducing the medication in patients previously treated with lifestyle alone. Historically, patients and providers thought that weight loss medications could be used to produce an initial weight loss that could subsequently be sustained by behavioral means. However, the available evidence does not support this view. Much as antihypertensive medications lower blood pressure to a new steady state with blood pressure rising to baseline levels upon discontinuing the medication, weight loss medications promote weight loss to a new steady state with gradual weight gain typically occurring when the medications are stopped. Medications act to amplify the effect of behavioral changes to consume fewer calories. They do not work on their own. To get maximal efficacy, obesity drugs should be used as adjuncts to lifestyle change therapy, and in some cases, weight loss is limited without lifestyle change. So the available pharmacotherapy approved for weight loss includes liraglutide, phentermine, and then phentermine topiramate, orlistat, lorcaserin, naltrexone combined with bupropion. I'm going to dig a little bit deeper into liraglutide as this is the most recent one and it's really gaining a lot of attention in the news. So liraglutide, it was studied using the scale trials for weight loss, and I'll go into 2 of the scale trials that were conducted. So the first one was a 56-week randomized placebo-controlled trial aimed to evaluate the efficacy and safety of 3 milligrams of liraglutide injected sub-Q once daily. It was conducted at 191 sites, and the trial enrolled patients 18 years of age or older who had a stable body weight and a BMI of 30 or higher, or a BMI of 27 or higher if the patient had untreated hyperlipidemia or hypertension, which does meet the criteria of our pharmacotherapy stated by the guidelines. Key exclusion criteria were type 1 or type 2 diabetes, but patients could still have prediabetes. But they were also excluded if they were using medications that cause clinically significant weight gain or loss, previous bariatric surgery, a history of pancreatitis, a history of major depressive disorder or other severe psychiatric disorders, and then a family or personal history of multiple endocrine neoplasia type 2 or familial medullary thyroid carcinoma. Patients either received liraglutide or placebo, and all patients had standardized counseling on lifestyle modifications approximately monthly. After 56 weeks, patients in the liraglutide group who did not have prediabetes at screening were randomly assigned in a 1-to-1 ratio to continue to receive liraglutide or switch to placebo for 12 weeks to assess whether efficacy was maintained after discontinuation. Because lifestyle modifications are so important, I want to dive a little deeper into what exactly the authors did for this intervention. So standardized dietary and exercise counseling was provided in individual or group sessions up to week 68, and patients were advised to increase their physical activity to at least 150 minutes per week and to reduce their daily energy intake to 500 kilocalories below their individualized energy requirements. So again, that does meet the previous recommendations that I just talked about. Now, the recommended macronutrient distribution was 30% of energy from fat, 20% from protein, and 50% from carbohydrates. So to encourage adherence, pedometers were provided, and a 3-day food diary was dispensed for completion every second month. The 3 pre-specified co-primary endpoints assessed at week 56 were weight change from baseline, the proportion of patients who lost at least 5% of their baseline body weight, and then the portion that lost more than 10% of their baseline body weight. Secondary endpoints included change from the baseline in BMI, waist circumference, glycemic control variables, cardiometabolic biomarkers, and health-related quality of life. So this slide shows the baseline characteristics broken into groups with normal glycemia and prediabetes. So the average age was 41 and consisted mainly of white females. There were a few patients that were classified as overweight, but it was split pretty evenly between the classes of obesity. There were higher incidences of cardiovascular disease in the prediabetes group, which is as expected, but overall was a fairly low rate in the population. So after 56 weeks, patients in the liraglutide group had lost a mean of 8% of their body weight, whereas patients in the placebo group had lost a mean of 2.6% of their body weight. Likewise, the liraglutide group had lost a mean of 8.4 kilos compared to 2.8 in the placebo group. Both of these endpoints did reach statistical significance, but note that the standard deviation is pretty wide in both groups. The estimated treatment difference overall was about 5 kilos, which is equivalent to about 12 pounds. 63 and 33% achieved a weight loss of greater 5% and 10% respectively in the treatment group compared to 27 and 10 in the placebo group, which also reached statistical significance. The liraglutide group also had a greater reduction than the placebo group in mean waist circumference and BMI, which makes sense due to the greater amount of weight loss. And as expected, the liraglutide group had a greater reduction in hemoglobin A1C that was significant. Multiple sensitivity analyses were performed, and liraglutide appeared to be less effective in patients with a mean BMI of 40 or higher than in those with the lower BMI. There was a greater reduction, again, like I said, in the hemoglobin, fasting glucose, and fasting insulin levels in the liraglutide group than in placebo. And measures of insulin resistance and beta cell function also showed improvement in the liraglutide group as compared with placebo. The prevalence of prediabetes was significantly lower in the treatment group, and then type 2 diabetes patients developed, or type 2 diabetes developed in more patients in the placebo group compared to the liraglutide group during the course of treatment. And weight loss with liraglutide was maintained over 56 weeks and was similar regardless of prediabetes status. The most common side effects in the liraglutide group were related to the GI system. As you can see, nausea occurred in 40% of the treatment group compared to 14% in the placebo group, and vomiting again occurred in 16% compared to 4%. These effects occurred primarily within the first 4 to 8 weeks after initiation of liraglutide. The incidence of serious adverse events was higher in the liraglutide group than in the placebo group, including gallbladder-related events. And most of the patients who reported cholestasis underwent an elective cholecystectomy, and most recovered or continued their assigned course of treatment. Overall, 11 cases of pancreatitis were confirmed, and these cases occurred in 10 in about 2,500 of patients in the liraglutide group, and 9 of those cases were graded as mild. Pre-specified cardiovascular events were similar between the two groups. And of course, patients in the treatment group had 10% noted of decreased appetites compared to 3% in the placebo group. And then the last trial that I want to go over is the trial that looked at the safety and efficacy of liraglutide for weight management, specifically in patients with type 2 diabetes. Again, this was conducted over 56 weeks and was randomized, double-blind, placebo-controlled, parallel group at 126 sites. Interestingly, a 12-week observational off-drug follow-up period was included to assess treatment cessation effects. So the total study length was 68 weeks. So eligible patients, again, had to be diagnosed with type 2 diabetes with an A1C level between 7 and 10%, and treated with diet and exercise alone or in combination with 1 to 3 hypoglycemic agents. And the agents they included was metformin, the TZDs, and the sulfonylureas. Patients taking sulfonylureas were asked to reduce their dose by half to lessen the chance of hypoglycemia. Patients were overweight or obese with a BMI greater than 27. And exclusion criteria included a history of pancreatitis, and also really similar to our exclusion criteria of the last trial. Participants were randomly assigned to one of 3 groups: liraglutide 3 milligrams, liraglutide 1.8, or placebo in a 2-to-1 ratio. More participants were included in the 3 milligram group because of the safety of the 1.8 milligram dose was previously extensively tested in patients with type 2 diabetes. Individuals were encouraged to follow lifestyle modifications that were equivalent to the previous scale trials. And 3 co-primary endpoints were tested: the relative change in body weight, the proportion of participants losing 5% or more of their body weight, and then the percentage losing 10% or more of their body weight. So this slide again shows baseline demographics, and the average age was 55, which is slightly higher than the last trial, and there was a good mix of male and female patients. The average body weight was around 105, with the BMI similar between the groups, around 37. 25 to 30% of the patients were classified as obese, and then the average waist circumference was 118 centimeters, and a low percentage had cardiovascular disease. Over half the patients were on metformin alone, with the next highest group being on metformin and sulfonylureas. Not shown on this slide, but the average A1C was 8% for the 3 populations, with an average fasting glucose mean of 160. So looking at the results, mean weight losses of 6%, 4.7%, and 2.2% respectively were observed. Weight loss was greater with the liraglutide 3 milligram and liraglutide 1.8 milligram than placebo for all 3 co-primary endpoints. There was a significantly higher proportion of participants who lost 5% or more than 10% of body weight with the liraglutide compared to placebo. Significant reductions in mean waist circumference of 6.1, 4.8, and 2.7 were seen, and a BMI reduction about 2.2 for the liraglutide 3 milligram group. And then the liraglutide was associated with significantly better glycemic control compared with placebo. And all of these were statistically significant. I really like this chart as it shows that it takes up to 50 weeks to really see the full effect of liraglutide. And after the drug is discontinued, some weight is regained. And also the glucose levels rise to around baseline after discontinuation as well. The study wasn't powered enough to make definite conclusions about safety, but the event rates for adverse events were higher with the liraglutide group than placebo, mainly driven by a higher rate of GI adverse effects. Also, there was a mean heart rate increase of about 2 beats per minute with the liraglutide compared to placebo. But in this study, no cases of acute pancreatitis were reported. So now that we went over the trials, they had pretty robust data in weight loss. So I just kind of want to talk about the dosing and how liraglutide works. It is a long-acting analog of human GLP-1, which is incretin hormone that increases glucose-dependent insulin secretion. It decreases inappropriate glucagon secretion, it increases beta cell growth, and it slows gastric emptying, and it decreases your food intake. The GLP-1 receptor is present in several areas of the brain involved appetite regulation. So unlike human GLP-1, synthetic GLP-1 receptor agonists are resistant to the metabolic degradation by the DPP4s and exhibit a longer half-life. So the average mean weight loss with liraglutide is around 5.8 kilos, with the most significant adverse drug reactions being the GI effects, such as the nausea, vomiting that I previously talked about. Liraglutide is contraindicated in thyroid cancer and multiple endocrine neoplasia type 2. It should be initiated at a dose of 0.6, and then it can be increased by 0.6 per week up to a maximum of 3 milligrams. It's very important that you do this dose titration so you don't get side effects such as nausea. And if the patient does get nausea, the dose shouldn't be increased until further tolerated. So phentermine is a sympathopathic amine commonly known as an anoretic. Phentermine acts by modulating central norepinephrine and dopamine receptors through promotion of catecholamine release. It's thought that food intake is reduced by causing early satiety. During studies, it has shown a mean weight loss of 3.6 kilos, but is only approved for the short term, up to 12 weeks, for the treatment of obesity, and the starting dose is 37.5 mg per day. It can cause a multitude of cardiovascular, CNS, GI, and endocrine side effects. Some of the more common side effects include headache, elevated blood pressure, elevated heart rate, insomnia, dry mouth, constipation, and anxiety. So it does have a lot of side effects. You want to avoid using this at night to help prevent insomnia. Also notice the long list of contraindications, including history of anxiety disorder, uncontrolled hypertension or seizures, hyperthyroidism, or history of drug abuse. So although phentermine is FDA approved for weight loss, it is not approved for long use. And this really presents a problem for clinicians because it's clear that weight gain will likely occur once the medication is stopped. So given the wide clinical prescribing of phentermine for more than 20 years and the lack of serious side effects, even in the absence of long-term controlled safety and efficacy data, it seems reasonable for clinicians to prescribe phentermine long-term or intermittently as long as the patient doesn't have any evidence of serious cardiovascular disease, doesn't have a serious psychiatric or history of substance abuse, has been informed about weight loss medications that are FDA approved for long-term use and told that these have been documented to be safe and effective where this medication has not. And it doesn't demonstrate a clinically significant increase in pulse or blood pressure, and it demonstrates a significant weight loss while using these medications. And again, this thought is supported by the 2015 endocrine guidelines. This medication is pretty much really similar to Phentermine. The dose is 75 milligrams per day, and its mean weight loss is 3 kilograms. Again, it's approved only for short-term use for 12 weeks, but it has been studied in up to 52 weeks, I do believe. The next drug product I want to talk about is Phentermine combined with Topiramate. So Topiramate is an anti-epileptic drug, and the precise mechanism of action of Topiramate on chronic weight management is not really known, but may be due to its effects on both appetite suppression, induced by a combination of pharmacological effects, including augmenting the activity of the neurotransmitter gamma, the modulation of voltage-gated ion channels, and inhibition of the AMPA excitatory glutamate receptors, or inhibition of the carbonic anhydrase. So the average mean weight loss is almost double of Phentermine alone, and it's at 6.6 and 8.6 on the high dose. So for the Phentermine Topiramate extended release, it's necessary to escalate the dose when starting the medication. The data supports starting at a dose of 3.375/23 daily and maintaining this for at least 2 weeks. And then if the patient tolerates the medication, an increase to 7.5/46 is in order. And because of the more favorable tolerability profile of the 7.5/46 milligram dose, further escalation is only recommended for patients who have not lost 3% of their body weight at 12 weeks. In that case, the dose can be increased to 11.25/69 and then to 15/92. The product label recommends a gradual reduction of dose over 3 to 5 days because of the observation of seizures occurring when Topiramate was stopped abruptly in patients with epilepsy. So you can see the adverse drug reactions. Again, it's going to be very similar to Phentermine. And then you really want to be cautious of using this in patients with a history of renal stones due to the Topiramate component. And because of all of the side effects that it does have, you want to use after trialing these two medications that I'm getting ready to talk about. So Orlistat works by altering fat digestion by inhibiting pancreatic lipases. Fat is not completely hydrolyzed, and fecal fat excretion is increased, and it blocks absorption of 25 to 30% of fat calories. Less than 1% of an oral dose of Orlistat is absorbed, and what little is absorbed is degraded into 2 major metabolites. The mean weight loss is 2.9 to 3.4 kilos, and numerous studies show that initial weight loss is greater and weight regained is slowed. So 2 dosing techniques are available. 120 milligrams is prescription strength and should be taken TID, and 60 milligrams is OTC strength and should also be taken TID within an hour of foods containing fat. Side effects are mainly GI, including oily spotting, flatulence with discharge, fecal urgency, increased defecation, and fecal incontinence. These occur at rates about 15 to 30% and tend to happen early and stop as the patient learns how to avoid high-fat diets and sticking to the recommended intake of no more than 30% of fat. Another important adverse reaction is potential kidney injury. Due to fat malabsorption, binding of enteric calcium can result in less calcium to bind to oxalate, which can cause acute kidney injury. Severe liver injury has been reported rarely, and a causal relationship has not been established, but healthcare providers should still be aware of the potential damage. Due to binding of fat-soluble vitamins, it may decrease absorption of vitamin K, and potentially patients could need a warfarin adjustment. Again, vitamin A, D, E, and K, and beta-carotene is going to be affected, so you should suggest a multivitamin at bedtime. So in 2012, the FDA approved lorcaserin. If you remember from previous slides, serotonin reduces food intake, and this medication is a selective agonist of the serotonin 2C receptor, which will reduce appetite and therefore can lead to weight loss. Mean weight loss is similar to Orlistat at 3.6 kilograms, and adverse effects are generally mild and include headache, upper respiratory infections, nasopharyngitis, dizziness, nausea, and it can cause hypoglycemia if patients are on an oral diabetes medication. You can see the contraindications and precautions, and the dosing is 10 milligrams BID, and there's no need for titration. But in clinical trials, taking it daily produced nearly as much weight loss as twice a day. And I do want to point out that it is contraindicated with SSRIs, SNRIs, and MAOIs, as it can lead to potential serotonin syndromes. Moving on to the next drug, which combines an opioid antagonist and an antidepressant. Bupropion is a weak dopamine and norepinephrine reuptake inhibitor, which regulates food intake by altering the appetite regulatory center, and the relation with naltrexone, bupropion enhances efficacy due to the release of feedback inhibition of POMC neurons that naltrexone potentiates. The average mean weight loss is about 4.8% of body weight at 1 year, and it's available in 8/90 milligram combo tablets. One tablet should be started in the morning, and in 1 week, one tablet added before dinner. And as tolerated, the dose should be increased to 2 tablets in the morning the 3rd week, and 2 tablets before the evening meal the 4th week, to a maximum of 2 tablets twice daily. If side effects develop, then the dose should not be increased further until it's tolerated. Adverse drug reactions: nausea, constipation, headache, vomiting, dizziness, and does have a black box warning for increasing the risk of suicidal thoughts. And it's contraindicated in uncontrolled hypertension, bulimia, anorexia, or pregnancy. Also with a seizure disorder or history of seizures, long-term opioid or opiate agonist use, or acute opioid withdrawal. So dose adjustments: you do need to adjust the dose whenever it's administered with CYP2B6 inhibitors such as clopidogrel, and you're not to exceed 1 tablet. Same with a hepatic impairment and renal impairment. And then recommendations to reduce the risk of seizure is to not to exceed 360 milligrams of the bupropion component, escalate the dose gradually, and avoid co-administration with high-fat meals. So in uncontrolled hypertension or history of heart disease, it's recommended against using the sympathomimetic agents such as Phentermine. And again, we want to avoid using those in patients with CVD, as well as lorcaserin. So weight loss is difficult for most patients, and the patient's desire to restrict food and energy intake is counteracted by adaptive biological responses to weight loss. The fall in energy expenditure out of proportion to reduction in body mass and an increase in appetite that are observed after weight loss are associated with changes in a range of hormones. Some of these changes represent adaptive responses to weight loss and result in physiology that promotes weight regain. No approved weight loss medication appears to promote long-term thermogenesis, and these medications promote weight loss through effects on appetite and decreasing hunger, and perhaps by aiding and resisting food cues or by reducing caloric absorption. But again, weight loss is usually associated with a reduction in total energy expenditure that is out of proportion to changes in lean body mass. The primary determinant of resting energy expenditure appears to persist indefinitely as long as the reduced weight is maintained. So what does all that mean? Clinically, it means that the individual must reduce energy intake or increase energy expenditure indefinitely to sustain the weight loss. So after initial weight loss, some weight regain can be expected, and you should tell your patient that on average, with greater regain observed over longer periods of time, and most often individuals will see a gradual weight regain of 1 to 2 kilos per year. One way to help counter this is continued provision of a comprehensive weight loss maintenance program on site or by telephone for periods up to 2.5 years after initial weight loss. And also, guidelines recommend that for weight loss maintenance, prescribe at least weekly self-weighing, face-to-face, or telephone-delivered weight loss maintenance programs that provide regular contact with a trained interventionalist who helps participants engage in high levels of physical activity, 200 and 300 minutes per week, to monitor their weight regularly and consume a reduced calorie diet. Of overweight obese adults who participate in a high-intensity long-term lifestyle, 35 to 60% maintain a loss of 5% of their body weight at 2 years follow-up. So this is just a chart of the drugs associated with weight gain and alternatives that you possibly could use. Again, this was from the 2015 endocrine guidelines. And what questions do you guys have?
Hey, Dana, this is Chris. I'm just curious, did you see any data comparing the Phentermine topiramate combination to just topiramate alone? I know you looked at it with, I thought I saw data with Phentermine alone, but.
Yeah, I did not. It would be something good to look at. I'm assuming that the combination would promote more weight loss.
Could you speak more about the oily discharge with Orlistat? I'm just kidding.
But yeah, I honestly, just the biggest thing is patients are going to regain the weight after they lose it. They have to work really, really hard to keep the weight off.
Dana, in all seriousness, the oily discharge, you said that it goes away not just because of time like metformin, well, not that it has an oily discharge, but just the GI upset goes away eventually, but it's because they learn to eat different foods. Otherwise, it would continue.
Yes, correct. So with Orlistat, really it's recommended not to eat more than 30% of your calories in a meal from fat. Because if you eat a really high fat loaded meal, like go and get a burger from McDonald's, you're going to have a lot of GI effects.
Okay. Thanks. This was great, by the way.
Thank you. I was cutting short on time, so I kind of rushed through the end. So if you have any questions, just let me know.
No, it was awesome. Thanks so much for taking time to do this.
You're welcome.
Any other questions? All right. Thank you, everyone. Have a wonderful Labor Day weekend, and we'll see you next week.